Hello and welcome to part one of two presentations on the elbow. We start with a short review of the normal anatomy, and then we'll look at mechanisms of injury, the importance of the correct radiographic technique in acquiring the images, and then we'll use clinical cases to demonstrate a range of fractures. Here's a reminder of the normal radiographic anatomy of the elbow on the AP projection. You may wish to pause the video or just let it roll. And similarly, here is the lateral projection. Again, pause the video if you wish or just let it roll and we'll move on. When we think about the pediatric elbow, remember the crytol or the crito mnemonic. Whichever you prefer, but either way, just make sure you know where the anatomical features are before you move on. And finally, let's just remind ourselves about the ligamentous anatomy before we get into the clinical cases.
The elbow joint has two fat pads that reside within the joint capsule. And it is the appearance of these fat pads that can alert the radiographer to underlying trauma. Now remember, fat is visualised as a dark grey appearance in comparison to the lighter grey of the surrounding soft tissue structures. The anterior fat pad is visualised as a small dark triangle lying anterior to the distal humerus, situated just above the capitulum. In comparison, the posterior fat pad is not visualised on the lateral view because it resides within the olecranon fossa and therefore it's hidden. Now, just a word of warning, if the patient is imaged with their arm in extension or their elbow in extension, then what happens is the olecranon process then slots inside the olecranon fossa, which will cause the posterior fat pad to displace. So the posterior fat pad is visualised if the arm is in extension. However, it is not visualised, and that's really important, it is not visualised on the lateral view. If the patient sustains a fracture within the joint capsule, blood is extruded from the fracture site and causes the joint capsule to fill with blood. It's this increase in fluid volume within the joint capsule that displaces the fat pads so that we can visualise the posterior fat pad, which normally is hidden within the olecranon fossa or a normal lateral view, and displaces the anterior fat pad. Now, the anterior fat pad, as we remember, is normally a small dark triangle adjacent to the anterior cortex of the distal humerus. And here the fracture has caused the anterior fat pad to billow out like the sail of a boat. And here on the posterior aspect of the distal humerus, we can now visualise the fat pad, the posterior fat pad, as it has been displaced out of the olecranon fossa by the fluid, increase in fluid. If you look carefully, rather than a smooth contour between the radial head and neck, there is now a sharp angulation indicating that this patient has sustained a radial neck fracture. The main mechanism of injury for elbow trauma is either an indirect trauma from an angular force. So the forearm, that serves as a lever against the angular force, and you get the fulcrum at the elbow, and it's usually a valgus injury. You can also get injuries from direct impact, direct blow, or fush, fall on outstretched hand. I'm going to briefly discuss a technique with you, as so many people image the elbow joint incorrectly. Unsurprisingly, patients who sustain an injury to their elbow joint are unwilling to fully extend it for the AP view. Now, there is a school of thought that for a modified AP, you can take the flexed elbow joint and position it so that the olecranon is adjacent to the digital receptor, and that the humerus, distal humerus, and proximal radius and ulna form 45 degrees with the receptor. The problem with this is that you don't get adequate visualization of either the distal humerus or the proximal radius and ulna because of foreshortening or elongation, and therefore it renders it a very inadequate view. Now, age is a really good predictor for the elbow to guess what type of injury might the patient have sustained. So, for example, the most common injury to adults is a fracture of the radial head or neck, and therefore the most appropriate modified AP view, if the patient is unable to fully extend their elbow joint, is to position it so that the proximal radius and ulna is adjacent to the digital receptor, because that allows for adequate visualization of the most likely area to sustain an injury. Conversely, the most common injuries in paediatrics is a fracture to their supracondylar region. And therefore, if you're going to image a paediatric and do a modified view, you position the patient so that the distal humerus is adjacent to the digital receptor, and therefore you're getting excellent visualization of this region. Obviously, if the patient demonstrates no injury to these areas, you will need to then go on and do an additional view. So if you was an adult, you would position it as though you're imaging a paediatric, and conversely, if you're imaging a paediatric, you do that second view as though you're imaging an adult. But that's only if you can't find an injury. It's important when imaging the lateral view that the elbow joint is at the same level as the shoulder joint. We can see from this view that the shoulder is significantly higher than the elbow, and what happens is that you get a lack of superimposition of the capitulum and the trochlear, and therefore this makes for a very rotated elbow view. So to reduce rotation, to make sure that the capitulum and the trochlear are superimposed, always position the elbow at the same level as the shoulder. The other really common mistake we are taught with an elbow view is to rotate the hand so that it is in the lateral view, thereby causing the radial head to be rotated clear from the proximal ulna. The problem with this is that the most common injury, as already mentioned in adults, is a fracture to the radial head or neck, and therefore if we think back to our anatomy, the proximal radial ulnar joint and the distal radial ulnar joint are pivot joints, and so if you're asking your patient to pivot the hand to the lateral view, this will hurt the patient. The best way to allow for good visualization of the radial head from being superimposed over the proximal ulnar is actually to take a 15-degree pad and position it under the pronated hand, ensuring that the widest portion of the 15-degree pad is towards the fingertips and the thinnest portion is towards the wrist. And by elevating the wrist 15 degrees, it allows for a good visualization of the radial head and neck, and it doesn't hurt the patient. Fractures of the distal humerus nearly always involve the articular surface. And of these injuries, 50% are either bicondylar, i.e. involving both condyles, or intercondylar fractures. You can get transcondylar fractures, and they're equivalent of the adult form of the paediatric supracondylar fracture. A significant proportion of these are severely comminuted, and 10% are isolated capitulum fractures. Bicondylar or intercondylar fractures will have a vertical component that extends to the articular surface. And this vertical component is going to lie somewhere between the trochlear groove and the capitellotrochlear sulcus. It will then divide either horizontally or obliquely to the distal humerus. You frequently get comminution, and you will get displacement and rotation because of the muscle attachments. Here we have an intercondylar fracture. It's an intercondylar fracture because the sagittal fracture line extends down to the articular surface, separating the capitulum from the trochlea. But it's not a bicondylar fracture because the fracture does not extend out to break off the two condyles separately. If we look carefully, we can see that the capitulum articular surface is nice and smooth, and rather than forming a smooth curve to form the natural contour with the trochlea, there is a disruption indicating that the articular surface has been broken and slightly angulated. So the sagittal fracture extends down to the articular surface, causing a disruption to the normal alignment between the capitulum and the trochlea. So what is it? It's a fracture where it's an intercondylar distal humerus. How? Intra-articular and incomplete. It's an incomplete fracture because the fracture does not break off into a separate fragment. And it's important that in the what, where and how that you say that it is an intra-articular fracture, because that's the significant injury to it. Now here we have a bicondylar fracture, so we can see the sagittal fracture extending between the trochlea and the capitulum, and then the fracture has separated out into a T-shaped deformity, causing the medial condyle to be separated off from the lateral condyle. So we have three very distinct fractures here. So there's the fracture of the distal humerus with the sagittal fracture causing 1, 2, 3 different fragments. So this is a comminuted fracture. So the important thing to talk about with this injury is that it's comminuted because the surgeon needs to know about putting these bits together, and the fact that it's intra-articular. We can see that the distal humerus lies here, whereas the medial epicondyle is here and the lateral epicondyle is here. So therefore there is significant overlap of the fracture fragments. Again, that's really important because the surgeon knows that they're going to have to reduce that to put it back into the correct position. So what is it? It's a fracture where it's a bicondylar distal humerus. How? So it's intra-articular, it's comminuted, and there's significant overlap. They're the three really important things that you need to comment on. Here we have a transcondylar fracture. If you remember from earlier, this is the adult equivalent of a supracondylar fracture, and so therefore both condyles are involved. Here we have our medial epicondyle, and over here we have our lateral epicondyle, and we have a transverse fracture that bisects both and passes through the olecranon and chronoid foci. Now the important thing to note is whether there's displacement or not. So let's have a look. Here is the distal portion of a proximal fragment laterally, and here is the distal portion of a proximal fragment medially, and medially here is the proximal portion of a distal fragment, and over on the lateral aspect here is the proximal portion of our distal fragment, and we can see that the two portions don't actually quite line up, and so therefore there is displacement here. There's only slight displacement, it won't take very much to align it, but it's something that you will need to comment on. So what is it? It's a fracture. Where? Transcondylar distal humerus. How? Slightly displaced. Capitulum fractures can be very difficult to identify, so it's important to pay close attention. Remember, when you evaluate your X-ray, you have to go around the cortex of each and every bone and to make sure that this cortex is intact. If we look carefully at the trochlear, we have this nice normal bow tie shape to it, and then suddenly where the capitulum should be, we have lost the cortex. It's not there. If you look carefully, you can see a sliver of cortical rim just here, demonstrated as a sclerotic curved line. And this is the capitulum that has been retracted proximally. It is the lateral view that will demonstrate the classic fracture appearance to the capitulum, whereby the fracture fragment is retracted anterosuperiorly, and we can see that the articular surface of the capitulum points superiorly and the fracture fragment points inferiorly. This image is also very good at demonstrating the anterior fat pad that's blown up into a sail sign, and we can visualize that posterior fat pad indicating there is a joint effusion present, and that's because the capitulum fracture has occurred within the joint, thereby creating that joint effusion. So what is it? It's a fracture. Where? It's the capitulum. How? Retracted anterosuperiorly. Fractures of the radial head and neck are the most common fractures in the adult elbow, so it's important to scrutinise this area carefully. We can see how the fracture bisects the head and down out through the neck, but the important component is the fact that the head is involved, because this makes it an intra-articular fracture. If you look carefully at the articular rim of the radial head, there is a slight depression between the fracture site. This indicates that there is a minimal amount of displacement between the two fracture sites. So what is it? It's a fracture. Where? Radial head. How? Intra-articular and minimally displaced. Radial neck fractures can be very subtle. You should have a normal smooth contour between the radial head and neck. So when you see a sharp angulation or a step, this indicates that there's an underlying fracture. And if we look carefully, we can see the cortex of the radial head and then the cortex of the adjacent radial neck are slightly separated, indicating there is a fracture through here. If we look at the lateral view, the radial head and neck should have a nice, smooth, continuous contour, but here we have a sharp angulation between the two, and if you look carefully, you can see this thin sclerotic line indicating where the fracture is. Now, although the radial neck fracture is not an intra-articular fracture, it is an intracapsular fracture, and so therefore you'll get an elbow joint effusion. And we can see quite clearly here there's a nice sail sign of the anterior fat pad, and there's visualization of the posterior fat pad. So therefore we know that this is an is there is definitely a fracture through this radial neck. So what is it? It's a fracture. Where? The radial neck. How? Slight displacement. Fractures of the olecranon can be very difficult to spot on the AP view, so it's important to know your anatomy. If you think about it, the olecranon comes up like so and across and down. But here we have this rather dense area of increased sclerosis indicating a bony fragment that has detached, and it's situated in a completely abnormal location. The trochlear and the capitulum have the coronoid and olecranon fossa situated above them, and this area of increased lucency is no longer visible, indicating that this bone fragment has migrated to superimpose over that region. If you look carefully, we have a very dark area here. So we know that soft tissue is light grey, fat is dark grey, and air is very, very dark grey / black. And so therefore we have air within the joint, and that's an important thing to note, because that indicates that therefore it must be an open fracture for air to get into the soft tissues. And now all is clear when you look at the lateral view. If we think about our soft tissue anatomy, the triceps inserts into the olecranon process, and what has happened is that this fracture fragment has meant that the triceps has retracted the fracture fragment proximally. If you look carefully, we don't have any evidence of any fat pads. And that's because the joint capsule has become torn because it's such a significant injury. And because the joint capsule is torn, it is allowing the fluid and blood to escape out of the joint space, hence not having a joint effusion. But now we can clearly see the subcutaneous emphysema, i.e. the air that has now been caught up within the soft tissues. And this subcutaneous emphysema is very important because it means that this fracture is an open injury, and therefore there's a high risk of infection getting in. So what is it? It's a fracture. Where? It's the olecranon. How? It's open, it's intra-articular, and there's severe distraction. Fractures of the coronoid process can be particularly hard to see because of the overlapping radial head. The brachialis muscle inserts into the coronoid process. However, the most common cause of fractures to the coronoid process is by elbow dislocation. So whenever you have a dislocated elbow, it's important to scrutinise the coronoid process carefully for any underlying fractures. As always, the soft tissue structures will highlight us to the fact that there is an underlying intracapsular injury, and we can see quite clearly that there is an elbow joint effusion with a sale sign of the anterior fat pad and evidence of the posterior fat pad posteriorly. So what is it? It's a fracture. Where? The coronoid process. How? Displaced. Dislocated elbows aren't particularly common, however they do occur. And it's important to make sure that you have your bearings so that you know in which direction it's gone. By far, the most common direction is either posterior or posterolateral. So let's work out where the bones are. This is our trochlear, so therefore this is medial, and this is our capitulum, so therefore this is lateral. So the radius is always on the lateral aspect, and so this is the ulna on the medial aspect. So when we talk about fractures or when we talk about dislocations, we always talk about the distal fragment in relation to the proximal fragment. So here we can see that our ulna and our radius has moved laterally. Now let's look at the lateral view. So again, remember, we always talk about the distal fragment in relation to the proximal fragment. So here we have our radius and our ulna, and this has moved posterior in relation to our humerus. So therefore we have a posterolateral dislocation of the elbow joint. And remember, check your coronoid process carefully for any undisplaced fractures. So what is it? It's a dislocation. Where? The right elbow joint. How? Posterolateral displacement. We've now come to the end of part 1 of the forearm and elbow, and I look forward to catching up with you with part 2.